Good evening, everyone. And thank you, Janet, for that very kind introduction. Tonight, I am tasked to discuss with you a very important topic in the management of patients with acute respiratory distress syndrome. Sedation, hand in hand with analgesia, are theoretically very easy to learn. After all, it is just, in essence, pharmacology, right? But in clinical practice, it is very complex and complicated to apply. So before I dive deep into the topic, let me give you a brief overview of the situation in terms of sedation practices across the globe. So the sheer magnitude and severity of the pandemic led to a significant and increased demand for sedatives and opioids. Several studies looking into changes into our approach to sedation of COVID-19 patients found that they tend to lean towards a deeper level than what most current guidelines would suggest. And this tendency to use deeper sedation is driven primarily by concerns that the lung injury we see in COVID 19 require more aggressive ventilatory strategies. Also, there are fears of exposure by healthcare workers in the event of self extubation with a lighter depth of sedation. We've also seen substitutions of drugs that were less frequently used pre-COVID era for ARDS patients, primarily fueled by shortages in both medicine supply and staff. So this slide just shows you two studies. One is a comparative study of non-COVID versus COVID patients, showing frequency of survival and extubation vis-a-vis the patient's cognitive function while on mechanical ventilation. And it shows that patients with COVID-19 related ARDS were more likely to be in a comatose state and had higher in-hospital mortality, represented here in the dark blue shaded areas. And they are usually at a RAS level equal or less than -3. The other slide, on the other hand, shows you a cohort study that investigated more than 2,000 patients with severe COVID-19 and found that acute brain dysfunction, coma or delirium, was more common and more prolonged than what is observed in other studies of patients with acute respiratory failure but without COVID-19. Also, patients with COVID-19 were more likely to have prolonged duration under sedation. About 2/3 were given benzodiazepines like midazolam and propofol for a median of 7 days. This raises the concern that we've reverted to outdated and potentially harmful treatment strategies, despite evidence-based management that espouses light sedation techniques, spontaneous awakening, and breathing trials. There seemed to be a higher prevalence and duration of delirium and coma in COVID-19 patients with ARDS, correlated with widespread use of midazolam infusions, immobilization, and isolation from families. So, as an anesthesiologist, I believe one of the hardest skill to master is the art of sedation. Whenever I teach sedation, I always show this table to illustrate the fact that even though theoretically we have clearly defined transitions from what is light or minimal sedation to moderate to deep, that is not always the case in practice. Sedation is a continuum. And the transition between wakefulness and unconsciousness is varied, wide, and oftentimes unclear. And it can be very difficult to determine where in the continuum the patient is. The three pillars of anesthesia, and no, it is not coffee, sitting down, or Sudoku, but rather hypnosis, analgesia, and immobility, unsurprisingly, are the same goals we target for our patients with ARDS, right? But unfortunately, there is no ideal drug or anesthetic, for that matter, in the OR and in the ICU. It is unavoidable that we resort to polypharmacy to achieve these effects. And because we work with these drugs, I think and I believe it is important for us to understand their pharmacologic characteristics, as it may affect our choice of what to use based on our targets and our patient-specific needs. So, just a very quick review. These are the common drugs that we use to achieve analgesia and sedation. And we know that the choice of the sedative or analgesic is as important as the dosing strategy in the outcome of patients with ARDS. And so it behooves us to understand at least their pharmacokinetic and pharmacodynamic properties. The first line sedatives to render a patient unconscious are propofol, dexmedetomidine, and midazolam. Remember that both propofol and midazolam are GABAergic and will reduce the respiratory drive and provide a deep level of sedation. Both, though, have no analgesic effect. Remember that. So consider, when it comes to midazolam, please consider a as needed, a PRN, or a scheduled intravenous dosing for before initiating continuous infusions. And keep in mind that the risk of delirium is quite high with midazolam compared with propofol. Now, just a brief data or information about propofol. It is the most frequently used intravenous anesthetic. Yes, it is an anesthetic. It has a rapid onset, a predictable context-sensitive half-time, and a rapid emergence after discontinuation. At low doses, it produces sedation, but increasing doses paradoxically will cause excitation, where the patient appears to be disinhibited and has unpredictable movement, has broken speech. Increasing the dose further will lead to loss of consciousness, apnea, muscle relaxation, and loss of brainstem reflexes. The time to offset is increased in elderly patients, especially for infusions more than 72 hours. And one of the rare yet fatal syndrome is propofol-related infusion syndrome, and is observed in critically ill patients receiving propofol in doses exceeding 4 milligrams per kilo per hour. So it is important to monitor these patients. And it is characterized by severe unexplained metabolic acidosis, arrhythmia, renal failure, rhabdomyolysis, and derangements in your electrolytes. Dexmedetomidine is a centrally acting alpha-2 agonist. It does not reduce the respiratory drive. It has analgesic sparing properties, but it is not possible to achieve a deep level of sedation with this drug. Remember that it comes with a black box warning and may cause hypotension, bradycardia, and sinus arrest, as well as hypertension and tachycardia in the context of withdrawal. At doses above 1.5 microgram per kilo per hour, it may increase the risk for cardiac toxicity and unlikely to add any clinical benefit. The first-line analgesics in the context of an ICU setting in patients with ARDS are opioids. They have fast onset of action, the effects are dose-dependent, and they have the ability to reduce excessive respiratory drive. However, adverse side effects include prolonged sedation, respiratory depression from drug accumulation, tolerance within 2 days, and signs of withdrawal after discontinuation, ill use, hyperalgesia, and chronic pain with prolonged use. A multimodal approach is suggested and may produce rather opioid sparing effects. So what are these non-opioid analgesics? What we have is paracetamol and ketamine at low doses. So the question is, why is my patient not waking up after I stop sedation, like after I stop infusion? And the explanation lies in this pharmacologic characteristic or parameter, and that is context-sensitive half-time. It is the time to achieve a 50% reduction in concentration after stopping a continuous infusion. And the context-sensitive half-time demonstrate the influence of the distributive process in governing drug disposition. So a drug that has a higher volume of distribution would mean that the patient may wake up faster, given that drug compared to, let's say, a different drug. So in this case, for example, propofol. Propofol has a very predictable context-sensitive half-time. So in a nutshell, the principle of analgo-sedation, analgesia-only based strategy, is that the priority should be given to analgesia before considering sedation. And sometimes the patient only needs an analgesic and doesn't have to be unconscious. A multimodal approach is always advised when we give analgesics. We need to, when it comes to sedatives, we need to minimize unjustified deep sedation. It's important to titrate the sedative based on pre-specified goals. And the goal is always comfort, a patient who is comfortable, cooperative, and calm. So much of the guidelines for the management of pain, agitation, delirium, and immobility have centered on frameworks and protocols such as the A2F bundle and geared at minimizing the use of benzodiazepine-based sedation, and as well as minimize the prevalence of delirium in mechanically ventilated patients. So, and this is why the focus is on analgesia first, and using light sedation strategies together with constant and close monitoring using validated subjective tools. So just a brief overview of some of the tools that we use at bedside. One would be the critical care pain observation tool, which was designed to assess the pain of critically ill patient who is otherwise incapable of reporting their pain. It is a behavioral pain scale, and the parameters are based on facial expressions, muscle tension, movement, as well as compliance with ventilated breath for intubated patients or vocalized pain for non-intubated patients. The other tool that we use at bedside, is the Richmond Agitation Sedation Score, or RAS. It is a validated and reliable method to assess a patient's level of sedation in the intensive care unit. So the advocacy is to use or to target RAS -2 to 0 to minimize sedation, because this strategy has been shown to reduce mortality and to decrease the duration of mechanical ventilation as well as the length of ICU stay. A RAS of -3 or less, on the other hand, have been shown to keep patients longer in intubated and in the ICU. And it's also correlated with higher mortality. The third tool used at bedside is the confusion assessment method for the ICU or CAM-ICU. Delirium has been shown to be associated with worse outcomes in critically ill patients. It remains underdiagnosed because sometimes the presentation is very subtle. So this scoring system helps monitor patients with regards to identifying the development of delirium or resolution of delirium. In 2007, there's a movie called Awake, where a young man undergoing heart transplant became the pop culture poster child for anesthesia awareness syndrome. Awareness under anesthesia is a rare experience that occurs when surgical patients can recall their surroundings or an event, even pressure or pain, while under general anesthesia. And so monitors were developed targeting, measuring the depth of anesthesia to prevent initially intraoperative awareness during surgery. And the most common tool or equipment out there is BIS and spectral entropy. A newer device that we use in the OR is called the CONOX, which measures Qcon, consciousness index, and Q-noxious index. So it uses a fuzzy logic algorithm of spectral EEG analysis. But what it tells us is it gives us an idea of the level of sedation. It is not a perfect tool for certain. It does have limitation. For example, in patients who are awake or agitated, artifacts will make the interpretation of the numbers very unreliable. But these are examples of objective monitors that perhaps we can apply in the ICU setting. So the BIS, Qcon, and Entropy, like I said, in some studies, it does have poor correlation between the numbers that you see on the BIS monitor and ICU sedation scale. But I think it has a role in patients needing deeper sedation. So, but then again, future investigations are needed to really validate. Now, a good rational approach in deciding between deep and light sedation is illustrated in this slide from Chumelo and Cozzi. They propose two clinical scenarios in the management of ARDS requiring different sedative targets. So in the acute phase, where the goal is to support vital functions, either to permit insertions of invasive lines, intubation, or change body positioning to prone, to decrease work of breathing, to minimize respiratory synchrony, perhaps our goal would be to target a deeper level of sedation. And in this phase, the commonly used subjective tools at bedside may not be enough. So at this point, perhaps we can use objective monitors like your BIS or your Qcon to help us determine the depth of sedation. So as the patient hopefully improves and the clinical challenges decreases and the initial hypoxic phase is slowly resolving, then perhaps that's the time we can target a lighter stage of sedation. So in this case, as you lighten the depth or the level of sedation, pain, agitation, and delirium symptoms may be adequately controlled using the smallest possible dose of drugs while maintaining a lighter plane. And also in this stage or in this phase, the commonly used validated tools like your CPOT, your RAS, and CAM-ICU can be used well. So the key points and summary of this talk is that the ideal balance between depth of sedation and ARDS management is very, very difficult to achieve. On one hand, there is the need to limit the harmful effects of mechanical ventilation, and on the other is the need to limit the harmful effects of prolonged deep sedation. So a rational approach would be to apply different strategies based on the varied needs of the patient, keeping in mind that sedation target changes, it's not unique, in the course of the ICU stay. In the acute hypoxic phase, wherein advanced airways are needed, placement of necessary invasive lines, and protective ventilation strategies are applied, a deeper level of sedation is required. And subsequently, aim for lighter sedation as soon as possible. So achieving sedation targets require constant communication between the members of the ICU team. Twice daily targets must be planned and should be flexible enough to monitor pain, sedation targets, as well as identification of delirium symptoms using subjective validated tools must be employed at bedside and performed regularly and frequently. And to ensure correct implementation of these skills, we need regular and continuous training of our staff as well. During deeper levels of sedation, in the acute hypoxic phase, subjective scoring systems are difficult to apply. And thus, more objective means of monitoring should be utilized. So examples are bispectral index, Entropy, and more recently, the Qcon index. However, again, these have poor correlation during awake and agitated states, and further research are needed. There are several published practice algorithms and protocols, and ICUs should adopt them. The primary recommendation when it comes to analgesia is to evaluate pain and maintain it at less than or equal to 4/10. Treatment must be implemented early. A multimodal approach to analgesia is recommended that is aimed at targeting the different sources of pain. Sedation targets at RAS 0 to -1 once the acute hypoxic phase resolves. A rational approach to manage episodes of severe agitation includes first verbal, and then pharmacologic, and lastly physical. Efforts must also be made to recognize the presence of and to identify modifiable risk factors of delirium. A tool like the CAM-ICU is used. Utilize non-pharmacological means as much as possible. Avoid benzodiazepines, as well as stop all therapies that contributes to the delirium. Thank you for your attention.